Our final presenter is Sam Skelton, Manual Handling Advisor for Cardiff and Vale University Health Board. Sam has 30 years healthcare experience and has been working in the field of manual handling for over 20 years. Sam is the only strategic lead and advisor for manual handling for 16,000 staff, covering both primary and secondary care. Sam is a key member of the multidisciplinary team involved with complex discharges and interventions at home to prevent admission to hospital. Sam is very passionate about keeping both staff and patients safe whilst undertaking manual handling. Sam is very dedicated to her role, recently awarded with a runner-up award in C&V People and Culture Services for Exceptional Service to People Award 2022, and is currently Secretary of the All Wales Manual Handling Advisors Forum.
My name is Sam Skelton. I'm the Manual Handling Advisor at Cardiff and Vale Health Board. I started working for the NHS in 1993. My clinical background is in dental nursing. I am still a registered healthcare professional with the General Dental Council, although I'm no longer practicing clinically. I started my journey in manual handling in 2002 as a corporate trainer, delivering the then new All Wales Manual Handling Passport Scheme to all staff across the organisation. In 2005, I moved to a senior trainer position and then was promoted to my current role as Manual Handling Advisor in 2007. I sit on the All Wales Manual Handling Advisors Strategic Group for Wales, and I have done so since becoming an advisor. I am currently the secretary for this group. Cardiff and Vale has a total bed management contract with Medstrom. This gives us access to a range of acute and community bariatric beds and mattresses. Included in the contract is a range of bariatric equipment for the acute setting. Medstrom also logistically manage a fleet of bariatric mobile hoists owned by the Health Board. This ensures the right equipment is with the right patient at the right time. Patients, when first admitted, are given our acute bariatric bed with a safe working load of 70 stone. This can be changed when the patient's weight is established, the patient's condition improves, or their rehab and discharge goals are planned. Mattresses are also managed this way. This allows patients to step up and down equipment as required. It is not a one-size-fits-all, and having this one-stop shop allows staff to select the right equipment when needed. The therapy staff are involved early on in establishing the mobility and function of the patient and setting rehab goals, ideally aiming to get the patient back to the level of mobility they were pre-admission. It is often at this point the manual handling advisor would be contacted for support for the more complex patients. There is an MDT approach to early mobilization. Ideally, we should be planning for discharge as close to admission as possible. This isn't always achievable, however. Admission to hospital is often a traumatic experience for this group of patients, at times involving the fire and the Welsh ambulance services for tricky retrievals. These services are not used for discharge home, as it is not classed as a medical emergency. This sometimes causes delays in discharge when trying to find suitable transport for getting our patients home. Another potential delay in discharge can be sourcing a suitable package of care for home. Often plus-size patients have not had any social care intervention prior to admission. At times, these can be very large packages of care involving 4 members of staff, 4 calls per day. And this always isn't able to be provided, and cost isn't always the issue. Care agencies can have a reluctance to accept packages of care as they feel there is an increased risk of injury to their staff, or they simply just don't have enough staff to manage the package. Delays in discharge can be very costly both to the organisation and to the patient. It is estimated that an overnight stay in an acute bed costs approximately £500 per night. Often plus-size patients require 2 bed spaces. A few months stay in hospital, which isn't unrealistic, can soon prove costly, particularly when the patient is medically fit for discharge. Delays also disrupt flow through the hospital, meaning patients are either waiting very long periods in A&E or planned admissions are delayed. The costs of the patient are there too. Patients often lose confidence after extended periods of time in bed to regain their pre-admission mobility, however limited that may be. Extended stays in hospital also increase the risk of infection and falls, which are traumatic for the patient and can be costly for the organisation if it results in further delays. The MDT have an essential role to find a solution to maintain or improve the mobility of the patient whilst in hospital. That could be something simple like reducing roll-in by introducing suitable turning mattresses to reduce the handling for staff. These interventions aim to reduce the package of care on discharge to the safest lower level possible by utilising equipment that can promote independence at home, minimise the manual handling required by carers, or even reduce the numbers of carers needed. Having Medstrom on board as part of the MDT team means that equipment can be trialled on the ward before the patient is discharged. This enables the patient to be familiar with the equipment and also allows ward staff to replicate the care package on the ward. This helps the therapy staff when compiling the care plan to hand over to the care agency on discharge, as we know if it works or if it doesn't. This approach should reduce the likelihood of failed discharges and patients being readmitted. Once equipment has been selected and trialled, the therapist will undertake a home assessment to check for space and access, ensuring there is suitable space for care to be given. Consideration also has to be given to the impact equipment can have on a patient's home life. This may mean that a living room is now a bedroom. This can impact on all the family and not just the patient. As I said earlier, this may also be the first care intervention that has taken place at the home. Carers visiting numerous times per day and providing personal care can impact on the patient's dignity and privacy, and this must always be regarded. Cardiff Joint Equipment Store procure and fund community equipment. This is managed then by them and by Medstrom. Medstrom clinical advisors provide training in all the equipment in their range to the ward staff. This is then followed up in the community for all caregivers as required. This supports the care plan that's prescribed by the therapist. Training in any other type of equipment is provided by the manual handling advisor and therapist as required at home. I'd like to share with you a patient journey to highlight how important it is to have appropriate equipment and support on discharge. In August 2021, a 65-year-old man was admitted to our acute hospital due to fluid collection. Prior to admission, he was fully independent, no care at home, living with his partner. He'd had a previous gastric sleeve operation approximately 10 months prior to admission. In September 2021, he was referred to the occupational therapist as the nursing staff were struggling to get the patient to the edge of the bed. He was taken between 2 and 4 staff. The patient was at the time being nursed on the MMO 8000 bed. This bed has full bed rails, which were preventing the patient from being able to get his legs onto the side of the bed. The rails were needed for support, so they were kind of in the way. The patient was then swapped onto the Barry 10A bed, as this bed had split side rails. However, this bed had quite a high height, which was causing an issue. When he was able to get his legs onto the side of the bed was too high, and he was then unable to stand. Also, the bed frame was causing a little bit of discomfort on the back of his legs. Therefore, he was swapped back to the MMO 8000. On the 22nd of September of the same year, the OT emailed myself and Medstrom to ask for some advice. They were also struggling to get him onto the edge of the bed. At the time, the patient was using the bedside chair, which was positioned next to the head of the bed, to pull himself forward with his left arm, and his right arm was then being used to pull on a member of staff so that he could come to sitting on the edge of the bed. At this date, the patient was weighing 170 kilograms. 2 days later, on the 24th of September, a joint visit was undertaken with myself, the occupational therapist, and the Medstrom clinic advisors. A risk assessment was done with Medstrom to establish if a static bed lever would be compatible with the current bed frame. We then looked at a positioning wedge at the foot of the bed for the patient to push his feet off, as he was too short to use the actual footboard of the bed. We had a discussion at this time with the patient that a community profiling bed would be needed on discharge, as prior to admission he was using a standard, home bed. On the 4th of October, another assessment was carried out with the manual handling advisor and the occupational therapist. This time we introduced a bed ladder to enable the patient to pull himself forward in the bed to try and diminish the pulling on the staff. The wedge at the foot of the bed was still being used, but it was still requiring quite a lot of effort and guidance from 2 members of staff. The following day, this gentleman had quite a lot of intervention, a joint visit again with the occupational therapist, myself, Medstrom re-attending, as the patient was still having quite a lot of difficulty getting out of bed and required a lot of assistance. The patient was now able to get into bed if the bed was positioned flat, and this also allowed the patient then to reposition himself. We ensured that he had slippers on his feet to allow grip when he was repositioning. But due to the difficulty in getting out of bed, we decided that that there would be no care package on discharge. A decision was made to look at trying in a different bed, a bed that could be used at home. And a recommendation at that date was made by Medstrom to trial the MMO 6000 bed, which has foot egress. On the 7th of October, Medstrom brought the bed to the ward to trial. It worked really well and the patient was able to get out of bed independently. The patient advised the ward staff that when he went home, he didn't want any care intervention and all care would be managed by his family and his partner. It was outlined to him at that time, for this to be a safe discharge, he would need to demonstrate to the ward staff that he could manage with the support of one member of staff only. And the discussion was made whether or not funding would be agreed for this bed, because this was a bed that wasn't routinely used at home in Cardiff at the time. So on the 11th of October, 4 days after the trial of the bed, a home access visit was undertaken with the occupational therapist and the Medstrom guys. The patient had his own property at this time, but he wished to be discharged home to his partner's flat, which was council-owned and was not on the ground floor. This meant that the lift would need to be used to pop the bed into. However, the internal dimensions of the lift were very small and would not allow the bed to fit in a standard position. A removals company were actually commissioned by the Health Board and Medstrom to help with the logistics of placing the bed on its side to fit into the lift. The next day, we were very lucky that funding was agreed for the bed by the head of integrated care, and the logistics then needed to be addressed in regards to delivery. Transport was provisionally arranged to take the patient home on the 15th of October. On the 13th of October, the very next day, the bed was taken from the ward to the patient's home by Medstrom, and on the 15th of October, he was discharged home. From the bed being trialled on the ward to the date of discharge was 8 days. This demonstrates having the right equipment, how quickly a discharge can happen. Unfortunately, the patient was readmitted for medical reasons on the 19th of October. During this time, the patient's bed stayed at home. While the patient was in hospital over the next few weeks, his mood and his mobility decreased. And then there was discussion of a suggestion of a care package at home when his next discharge took place. The patient absolutely refused. He didn't want any care intervention. So arrangements were made for a mobile hoist for home, and the family were trained in its use. Christmas Eve 2021, patient was discharged home, back onto the MMO 6000 bed. No care package, family supporting care. New Year's Eve, a week later, the occupational therapist rings the partner to find out how the discharge had gone, to be informed the patient was up and about, making cups of tea, hoist not being used, patient self-caring. February 22, partner ringing the occupational therapist to have all the equipment removed, the commode, the standing frame and the hoist. At this point, bed still in situ. Fast forward now, bed is still in use. I've literally had an email this morning to arrange collection of the bed. He's made so much progress. This gentleman is now driving, taking his grandchildren to activities. And the next step now, which we're already at, is popping him back onto a normal profile in bed with a long-term goal to go onto a standard bed at home with a bed lever. So to summarize, it's essential that we have speedy access to equipment and that an MDT approach is essential. We must document clinical reasoning and equipment solutions in advance of discharge. We work in partnership with our supplier, and this has been a key for us to ensure the equipment is scheduled and to support the carers or family with training. We monitor the patient's discharge and we follow up with reassessments to prevent readmission as we can. And it's really important that we document any outcomes. Thank you for listening.